Good morning, everybody. Thanks for tuning in. My name is Bill Chase. I'm the CEO with ARX. We are a small, relatively small revenue cycle support operation in Franklin, Tennessee. What I wanted to talk to you about today was talk a little bit about supply chain, about hospital healthcare supply chain. It's an interesting topic, and I think that there is a lot to it, a lot more than I guess I probably will be able to cover in just this short amount of time. But just very interesting. A lot of things that go on here that quite frankly I'm not sure everybody sees. To get started, if you go to the first slide, talks about the traditional hospital supply chain. When you look at that slide, I think that one of the things that I would suggest to you is that it's very linear. It's, each of the steps produce a supplier. Obviously, hospital, I won't read all the slides. There's not a lot of interaction between the between the five rather. Each of the participants is independent, really built to protect their own interest in most cases. The system is just fraught with manual processes, outdated processes, things like PAR levels and storage and inability to systematically find or electronically find supplies is all part of this process. And I think it's interesting that these outdated tools exist even when technology in this industry is at an all-time high. Oftentimes what we see with the hospital supply chain is that decisions are solely based on price, not always based on factors that really should be taken into consideration when considering the supplies that are used in the healthcare process. One of the statistics I found was that by 2025, it's estimated that $5.7 trillion will be spent on the supply chain, which only makes it really the number two expense, obviously. And the number one expense in healthcare is obviously payroll, but healthcare supply spending is a close number two at 5.7 trillion. On the next slide, I think that some of the variables, some of the things that need to be considered as you look at what the traditional model has been, can be summarized into four categories. Obviously, baby boomers, aging baby boomers is a big issue. That generation, which I'm part of actually, is dealing with chronic conditions, a lot of high risk, lots of different types of illnesses and conditions that require a lot of care, and certainly as a result require a lot of different supplies. Physician shortages, clinical shortage, staff shortages is obviously a big issue. Even if you take out of the situation what's going on with COVID currently, when you look at physicians and clinicians, you've got an aging workforce, obviously. Lots of issues with work-life balance. I had actually my own physician recently went offline, if I can say that, went to a boutique practice, for a whole lot of reasons, not the least of which was work-life balance. And clinician satisfaction. I think that when you read a lot of information about this or anything regarding clinicians, I think that there's a lot of frustration with that group about what they have to do and what they want to do and what they're allowed to do. Certainly that is a big factor. Rise of consumerism is a big issue. Patient experience, number one. Convenience is a big issue. I read something recently that said that 85% of healthcare happens outside the hospital environment, remote locations, convenient locations. So it's a big factor to consider. And then, nowadays you can look up anything, right? You can look up different hospital ratings and rankings, and that all impacts the profitability and the effectiveness of a hospital and how they attract patients. And then lastly, security and compliance. There's so many different restrictions and requirements that have been put on the whole industry: HIPAA, ACA, cybersecurity. I actually read a study recently that talked about how difficult over the next couple of years that it's even going to be to get cybersecurity insurance. If you can get it, it's going to be difficult to get, and obviously it's a huge issue for the industry. So when you look at all of these factors together, I think they certainly point towards a need for change, for an updated model. Everybody has their own figures. I've seen lots of different pieces of information about this, but basically on average, it's it's this, as the slide mentions, $25.4 billion is wasted annually in the supply chain. To give you some specifics of that, some examples of that, it's anywhere from 10 to 30% of projects expire on shelves, never get used and go past their shelf life. There are 4,500 or so recalls annually, whether it be drugs or devices or whatever, just lots and lots of supply spending that gets spent and then just gets recalled. There is a couple of the other facts that I thought were interesting was that it's estimated that 17% of a clinician's time is spent on supply management. 17%, when you have clinicians that really go into that line of work to spend time with patients and have them spend time on supply management, or a lot of it's paperwork too. There's some estimated 23 to 25% of a clinician's time is spent on paperwork as well. So it takes a lot of time away from the patients. I read another study that talked about nurses. My wife is a nurse, and she attested to this as well, that nurses spend roughly 20 minutes per shift looking for supplies. 20 minutes might not seem like much, but again, it takes away from patient care, which certainly has to be the goal as the overall goal. It was a Sage Growth survey of 100 hospital supply chain leaders that talked about this, and they said that 45% of those that responded state that the current supply chain efficiencies impact patient care. Just not something you can allow to happen, right? I mean, the whole goal needs to be, particularly when you're looking at a industry that is moving from pay for time or pay for quantity to results reimbursement or outcome reimbursement. Not taking care of the patient is certainly not going to fly. So going forward, I think that the healthcare value chain, we call it value chain here because I think it is based on value. Really, there's three things that need to be considered. Certainly needs to be care-centric. I think there's a number of ways you do that. I think you do it through physician involvement. Physicians need to be involved on both sides to be able to identify what supplies they need, what supplies they prefer, but also to show them what supplies actually result in better outcomes. Physicians can have certain preferences, obviously. They're certainly entitled to those, but oftentimes when you actually prove to them, show to them what the results are with a particular type of supplier, particular type of particular medication, whatever, you can go forward agreed on what the right option is, what the best option is. In that, I think that what you'll find is that there's a lot of supplies that are commodities. There is no discernible difference between an outcome based on one variety versus another, and those should be treated as commodities. But oftentimes there is a difference, and making sure that everybody's on the same page about what that difference is and how best to take advantage of what the best outcome is something that needs to be part of that value chain. Second part is that it needs to be outcome focused, obviously. I mentioned before that there's never been a time in this industry where there's been more technology. And I think that one of the places where we missed the benefit of that technology is just in data analysis, being able to tie outcomes back to the supplies that were used. The data is there, we just tie it back. And I think that's going to be critical going forward to be able to identify with good data, good information, how to choose certain supplies and what supplies in some cases it's worth paying more for. If you've got some sort of device or some sort of supply where you can prove that it results in shorter stays or less requirement for anesthesia or just overall better outcomes, there would be no reason not to do that. Additionally, I think from an outcome standpoint, it allows you to focus on proper labor utilization. I mentioned before that the number one complaints of clinicians in most cases is the amount of time that they can spend with patients. And I think that having a system that is built to attack that, to provide them the opportunity to spend the time with patients, clearly results in better outcomes. It's proven that the more time clinicians spend with patients, the better the outcome. And it certainly ends up impacting patient satisfaction as well, both from the standpoint of their outcome, but also with the time they get to spend with their doctor or with their nurses. And then lastly, has to be process driven. We're in a technology age. I think that, as I mentioned before, there's the ability to not only analyze data to look and see what the outcomes are, but to use that data, that analyzation of data, to predict and manage the future needs. Not all about par levels anymore. It's about understanding what you need and having it when you need it, where you need it. A lot of buzz talking about artificial intelligence, talking about what's available today, be able to use this information, these statistics to go forward looking at what is needed, even particular case by case, be able to look at a chart, have a patient in house, and be able to use artificial intelligence to tell you what most likely are you going to need to be able to predict that stuff going forward. And then also things like chatbots. I read a study that talked about how chatbots, if nothing else, should be available where if you're in an ER or you're in a patient room and you need to get some sort of supply, you get a chat box available and you can have it there when you need to get it there. Again, focused on the outcomes. So the supply chain model for 2022 and beyond, I think this diagram, this picture here shows what that should look like, how it's the intersection of the three items we talked about. As I mentioned earlier, current model for many hospitals is stagnant. There's plenty of opportunity, both for reduced spending and for better patient results, which clearly is the key. I think hospitals, their ability to compete effectively in an outcome-based revenue cycle will be key. Having a better supply chain is going to be key to that survival. Have to operate more efficiently, have to operate more cost effectively, but also get the right outcomes. I think the technology exists to provide these connections to break down the old silos. I read a study that talked about just overall about the U.S. healthcare system and what is needed to improve that as we go forward. And it basically boiled down to, they suggested 6 goals: safety, efficiency, effectiveness, timeliness, equity and value, and of course the patient. Obviously the patient doesn't need to be last, but that's the way it was presented in this study. I think when you look at a revamped supply chain, a future and beyond supply chain, it impacts all 6. And I think to be successful, to go forward, to navigate through all the changes in workforce and patient expectations and competing in this new healthcare environment, it's necessary to take every advantage you can get. So appreciate you tuning in. Watch for future videos from us as we go forward. I'd like to talk about the things we find interesting, and hope you do too. Thank you.